Support for this podcast comes from iTube.net. iTube is optometry's leading source for high-quality optometric videos, educational series, spotlights, and more.
Hey everybody, hopefully the music alerts you to the fact that we are here for another episode of Collaborative Corner, the podcast, CPTPC or something like that. I don't even know. I was thinking about it. It's the end of the year. It's our last episode of 2025. And I was thinking, how long have I been doing? I mean, the podcast has been going on for about a year, but Collaborative Corner has definitely been going on for, I think, almost 7 or 8 years. So for those of you that listen to every episode, why? I mean, seriously, it's all I have to say to you. And for those of you that enjoyed the video format, it's still on iTube. You can go watch it. So pretty exciting stuff there. You know, at the end of the year, I oftentimes too reflect on, could I have been a better clinician? Could I have been there more for my patients? When I walked in, should I spend more than, 2 minutes in the exam room? Questions that I'll just have to ponder at the end of the year. But one of the things that I'll be really honest with you is that, I miss having a pager so that I could look at a pager and look at a patient and go, oh, I got to run. I got to get out of here. We don't have that anymore. And the other thing that I really miss too is the fact that right now, when I can't figure something out, when I have no idea what I'm looking at, I'll usually say, I think it might be neural. I think it's something, I mean, obviously it must be something in your brain. And I look for somebody else. So I like to punt. I like to find people whose goal it is to empower others to do and see the things they enjoy in order to get the most joy and happiness out of life. I'm looking for a clinician who does that. In fact, I'm looking for somebody like Jacqueline Theis. Jackie, who is from Virginia Neuro-Optometry. Jackie went to school in, where'd you go to school? Because I noticed you went to Berkeley. So where did you do your undergrad at?
I did undergrad at Bucknell in Pennsylvania.
Oh, for crying out loud, Bucknell. Was that a good? No, hold on, water. Were you by the water? Am I doing a good Pennsylvania impression?
I mean, I'm not from there, so I'm from Colorado originally, but I think water.
Water.
I'm
Oh
not
yeah,
from there, so I don't know if I can do it.
the
Yeah.
the water. Hey, so take us on this journey really, really quickly. So you're in high school in Colorado. You say, I need to get out of Colorado. It's gorgeous. I love it here. And I need to go to Pennsylvania to a small college called Bucknell. And then you're like, you know what? Forget Bucknell. I'm going to go to optometry school in Berkeley. So you've gone from Colorado to Pennsylvania to California to Virginia. Okay, so I think the first thing I would ask is, have you seen a neuro-optometrist for yourself?
For myself,
Yeah, because that sounds crazy.
I have not actually.
My gosh. So just real quick, 30 seconds. Tell me, how did this, were you chasing somebody? Was there a love interest that you followed?
No. So I mean, how I got to Bucknell was my parents wouldn't let me go to CU Boulder because they said I'd have too much fun. So they were probably right. And so I had to go out of state. And Bucknell is a very work hard, play hard kind of school. So it was like the perfect fit. But it was cold. And so I just decided, I'm all done with cold. So then I decided to go to the West Coast for grad school. So it was pretty simple there. And then for neuro-optometry, so I was living in California for about a decade and I loved it except for the fires. The fires kind of ruined a lot of my quality of life because I'm a big runner and you can't run outside when there's soot in the air all the time. So I was just looking for a change. And I had kind of helped write this book, kind of small world being small. There was a neurologist in California who also went to Bucknell. So obviously we were fast friends. And I helped peer review her chapter on vision problems in brain injury for her book, Shaken Brain. And I was telling her, I'm looking to move. And she goes, well, I know the guy who wrote the textbook on brain injury. He lives in Virginia. You should talk to him. He knows everyone. And so she gave me his cell phone number and I called him. And we talked for about an hour. And after an hour, he was like, well, nobody does what you do. If you move to Virginia, I will sublet you space in my practice and you can start your own practice within my brain injury clinic. And so that's what I did.
That is crazy. So what was the name of the book? Chicken Brain? What was the name of the book?
Shaken brain.
Say it one more time.
Shaken brain.
Should we-
Shaken, like shake and bake.
Oh, a shaken brain. So it kind of like a concussion. I mean, okay, so I noticed you had written recently about looking through the static, exploring the link between visual snow and concussions. So is a lot of what you do more, people who've had, traumatic brain injuries? Is it more uh, younger kids that are coming to see you because of maybe visual, disturbances or um, inability to kind of, fusion type things? Or walk me through the day of a neuro-optometrist.
Yeah. Everyone's different in how their practice is set up, but mine is, I would say, probably about 90% brain injury. And within that, I would say, just like statistics of brain injury, about 90% of that is mild traumatic brain injury. So most of it's going to be concussion. And then 10-15% would be more severe, moderate traumatic brain injury, stroke. I see you can also have acquired brain injury from toxic fumes, or you can have acquired brain injury from chemical exposure, um, things like carbon monoxide poisoning. And then I also do see a lot of patients who have eye movement problems from neurodevelopmental problems. So cerebral palsy, Down syndrome, things like that. And then I always joke with some of my patients, like, oh, good. It's just a cranial nerve palsy. Like, so I do see double vision as well. Those are my easy patients. Like, you come in and like, oh, it's just double vision. You only have one complaint. Like, I can fix that.
Wait,
Uh,
you're diabetic and I can use Fresnel Prism on you?
yeah, it's
Hallelujah.
so
Yeah.
easy.
Yeah.
So, but yeah, I always say my practice, it's tertiary care only. I don't do primary care or contact lenses. So I tell all my local providers, think of me as the extra person in your office. I'm just in a different location because I see patients. I kind of do the neuro aspect, and then when they need primary care services, I send them back to their primary care doctor to handle those
That
issues.
is that is amazing because I mean, you're doing the yeoman's work because so, when I think of, concussions and I think of, traumatic injuries, it feels like it's a very long process. And more importantly, though, it's, a lot of what we do, like, let's say with dry eye and with other conditions that are chronic, there's really no end game. I know what we're doing is we're managing a condition that's never going to go away. I feel sometimes with patients, especially with traumatic brain injuries, that because it takes so long and they don't see the changes as quickly, you're doing a lot of hand holding. Is a lot of your practice just like therapy or is it diagnosis?
So earlier you were talking about how you only had, 2 minutes for an exam, and I laughed to myself because my intake exam is 90 minutes. And the beginning of that exam, the first 30 minutes is usually just listening to the patient. And the main reason is because by the time someone's come to see me, I don't do as much acute cushion anymore. I do mostly chronic. So you've had your concussion 2 or 3 years, you have multiple problems going on. I always say, if you were a simple concussion, someone else would have fixed you by the time you got to see us. And that's kind of our whole clinic. We have a physical therapist that does chronic pain and headache management. We have an occupational therapist that does dysautonomia and cognitive complaints. And we have our physiatrist that does kind of post-traumatic headache management and all over brain injury care. And we always think of ourselves as kind of the last resort. Like by the time you've seen us, you've seen everyone. And so my big thing is I don't want to try something someone's already tried. Um, but also there's a lot of other components that the reason the person's not better is because they just missed some small thing, right? Some small thing of, I'm really light sensitive all the time. And like, oh, by the way, when I go to bed at night, I get radiating pain. I'm like, oh, you just have occipital neuralgia. And I fix the occipital neuralgia by sending them to a pain specialist, and all of a sudden their light sensitivity is better. But if I hadn't talked to them that whole time to figure out all the other pain problems they have, I wouldn't have figured out where their light sensitivity was coming from. So I don't know if I would say I handhold as much as I try to sleuth. Like I'm trying to figure out why you're not better yet. Because even though brain injury is a disease causing injury, its chronicity is often because someone didn't figure out where the symptom generator was coming from. And if you figure out that symptom generator, you can get a lot of benefit and just kind of improved quality of life.
There's a show on CBS right now called Watson, and it's kind of a take on Sherlock Holmes and Watson. And, Dr. Watson opened up a clinic to do exactly what you're describing. No, it's almost like House, right? Where it's kind of like, what are we thinking? But So I guess, and for me, everything you're saying, I'm going to be really honest with you. I think I understood about a third of what you said. So, which is okay because I'm the guy who's going to be sending my patients out to Virginia to see you. Is what type of testing? I mean, how do you tackle some of these things? Because you said that these patients have already been seen usually like in a clinic, and so they've already gone through what dry eye protocols, or they've maybe tried specific types of colored lenses, or that type of therapy before they see you. I mean, I just help me here.
Yeah. So it's funny, a lot of the equipment that I use is all the old school stuff that we all learned back in the day and then just got newer versions of it and never went back. But I do, so for example, Schirmer's, I'm pretty sure Schirmer strips only exist for my clinic. Dry eye is incredibly common in patients with brain injury. And I look at these patients and they've seen multiple ophthalmologists and optometrists, and I look at what they're doing and they're on worm compresses and cyclosporin and artificial tears and nothing's helping. And then I do Schirmer's and I realize like, oh, you're just not secreting anything out of your lacrimal gland. And then I look at their medication list and I'm like, well, you're on, 8 medications that cause decreased lacrimal secretion. So at that point, you're looking at, I need either a stimulant to get those things, secreting a little bit more, or figuring out why those glands have gone down. And it's funny, but in brain injury, it's always the opposite. So I'm like, oh, hot compresses, try cold. And it's funny how much cold compresses end up working better for nerve dysfunction instead of hot compresses. And then I'm not using any immunomodulators. It's not an immune problem at that point for my patients. It's just evaporative. So I'm using more evaporative dry eye treatments, and it's just kind of changing the paradigm. And then I would say my binocular vision testing, it takes about 45 minutes. It's extensive. I've done research with some universities, and what we've found is that a lot of the ocular motor dysfunction and concussion is endurance based. So, and you can see that almost with their symptoms. It's not that they can't read, they just can't read very long. It's not that they can't go to the grocery store, they just can't do it very long before they get symptoms. And so, what we found in our research is that a lot of patients get their eye movement problems missed because the clinician didn't test them long enough. So, when I test saccades, I test them for a full minute in each direction. Most people don't
Wow.
do that. Right? Because you
No.
don't have time. You only have 2 minutes for the whole exam, right?
And that includes the intake, and that also includes me talking to the patient. So yeah, no, my saccades are follow. Beep, beep, yeah, okay, bye.
Yeah, you do the one clinical H and you're like, "I'm good."
Yeah.
And
Did you
so
see?
but
Did it get double? What? Never mind. Move
nope,
on.
not at all.
No.
And,
Okay.
and I repeat near point of convergence 3 times, and then sometimes I'll even do it, at the end of the exam. So maybe in the beginning of the exam, they had the reserve and their near point was great. I do the rest of my battery, come back to it because they complained of double vision, and all of a sudden now I see their near point's bad. And so it's more of an endurance game. And so part of that long testing is because studies have shown that it's the endurance of the ocular motor problem. And so things get missed because the exam was just too quick.
Do people have? So I mean, I'm harping on concussions because I think a lot of ODs, for general practice optometrists and myself, we see patients that come in who think they were concussed, or to be evaluated. Um, do they wake up in the morning better, and then as the day goes on, they fatigue, it gets worse, or are these symptoms consistent with these patients?
Yeah. So with ocular motor dysfunction, I always tell patients the symptoms should be triggerable with a visual task. So, for example, sometimes the symptom, like we always think, oh, blur, double vision, but a lot of the ocular motor symptoms that aren't vergence and accommodation, their symptoms are going to be dizziness with scrolling or nausea, with grocery shopping. And it's not right away. And so, one of my favorite questionnaires that I like to use is called the Visual Quality of Life Survey. And it'll say, how long can you do this task before you get symptoms? 0 to 5, 15 minutes, 15 to 30, 30 to 45. Because if someone comes into me and they're like, I can't read. I'm like, well, how long? I can't read and then I get a headache. I'm like, well, how long can you read? And they're like, 8 hours. I'm like, get out of here.
Yeah. Yeah.
Uh,
Seriously.
Me either. But
Yeah.
if someone comes in, they're like, I can't read for more than 5 minutes and I get a headache, that is a very different visual quality of life. And it's consistent. So it's not like, and definitely there's a fatigue factor. So people will notice the afternoons are going to be worse if I've been using my eyes in the morning. But there is a very big trigger of I can only go for X amount of time before that symptom comes around, and it's consistent. And that's kind of the other thing too, when I'm doing my intake and I'll say, how, if all of a sudden they were able to do 2 hours, 3 months ago, and then all of a sudden now they can only do 5 minutes, that's weird. Like, that's not concussion, because concussion is very much it was an event that occurred, and then you usually stay the same and get better. You'll have kind of I always say it's kind of like the stock market. It goes up and down, but overall you're trending upwards. And if all of a sudden something dramatically happens, that's a new injury, and you have to kinda look around at what that is. And that can kinda make it a little bit trickier, for sure. Because again, just because you had a concussion doesn't mean you couldn't also randomly have a stroke or also have a brain tumor. So you always have to have kind of that differential diagnosis ready when people aren't fitting that pattern.
You've mentioned the grocery store a couple times. Why just shopping, and having a concussion? What's the correlation there?
Oh, the grocery store is the hardest visual task for people to get back to. So we take it for granted. We run in, we grab the milk, we leave. But going to the grocery store is very hard for the brain because it's so multisensory, right? So you're walking in and you already have your working memory. I need, ketchup, I need peanut butter, I need bread. Don't ask me what I'm making with that.
I literally I'm getting hungry thinking about dipping my bread in peanut butter and ketchup. Yeah.
So, but then you're thinking, okay, so these are the 3 things I need. And then you're walking in, you've got fluorescent lights, which can be triggering for migraines. You've got music, you've got reflective floors, and then you've got visual search. And so now you're searching for the ketchup. Don't forget, you have to keep remembering that you need the ketchup. You're moving your head side to side. You're moving your eyes up and down, in and out. You also have some screaming kids somewhere else in the store. And then you're also making that cognitive decision. You finally, let's say, get to the peanut butter aisle. Do you want crunchy? Do you want smooth? Do you want discount? Do you want on brand? Like, there's so many little decisions you're making from a cognitive decision standpoint. And then when you really break down all those little aspects, you've got vestibular input, you've got cervical input, and visual and cognitive all working at the same time. And then people just leave and they leave the store and they're just absolutely exhausted. It's one of those that is so we don't think about it. You do it all the time and you're like, "Oh, this is no big deal." And someone with a brain injury, it's like asking them to run a marathon. It's almost
Yeah, that sounds so overwhelming. I mean, it's like going to Vegas where the carpet is intentionally just obnoxious, so your eyes will stay up, and then the blinking lights and the noise just to draw you there. I would assume that if you're concussed, that going to Vegas would be just horrible too.
yeah. And it's the little things and it cracks me up anytime it's because Christmas season, right? So we got all the lights.
Oh, yeah.
This one patient who I remember from a few years ago, and he would come into my office around Christmas time. He's like, "My neighbor hates me." And I'm like, "Have you told him you have a concussion and you don't like his blinking Christmas lights?" And he's like, "No, he does it on purpose." I'm like, "I'm pretty sure he does not do this on purpose, and he's just in the Christmas spirit." So
I feel that, bro. I feel like my neighbors do that too with their motion censored floodlight that just glares in our house, and I'm like, "Thank you. No, thank you."
I think a lot of brain injury so to the part of being a therapist, a lot of brain injury care is me getting my patient to be their own advocate, to, like,
Mhm.
go next door and tell them to turn the lights off or tell them to stop the flashing part, or, at some point, you do have to tell people you have a brain injury and then tell people what you need so that you're not triggered.
'Kay,
Um,
so I'm gonna do a little Missy Elliott. I'm gonna drop it, flip it, and reverse it.
Love it.
So for a little while, I was, evaluating workers' comp claims, and ever so often, I would get a workers' comp claim for somebody with a concussion. And this was a while ago, and I had to do research, whatever, but you have somebody, a general optometrist, who's evaluating it and then determining whether or not this person should be out of work, if they should be compensated. How do you differentiate patients that are malingerers or just not wanting to get better? I mean, is there a way that you can differentiate that, or am I just like just being just kind of, I don't know, not a nice person? Like I'm not.
I see a good amount of workers' comp, and I would say the majority of my patients wanna go back to work. Like, a lot of people are like, "Oh, it's great to not be off work." Sure, for, like, the first few weeks, but after being out of work for, like, 6 months, like, a lot of people go nuts, and they're like, "I just wanna go back to work." I would say that's the majority of my cases. The one thing I love about the eyes have numbers. I know exactly what numbers you should hit. I know how fast they should go. I know what symptoms they should provoke because 'cause I've been doing this for so long. And I know right, if I'm doing endurance testing on saccades, I have a pretty good idea at this point that if you can go for 45 seconds on my test, how long that visual quality of life usually matches up to, right? Like I can usually go for 45 minutes. So I have a pretty good idea that all of the symptoms you complained about have different eye movements related to them. I know that smooth pursuits are going to be involved in scrolling. I know that Convergence is going to be involved in reading for long periods of time. And so their symptoms need to match what my objective findings are. And if they don't match, that's when I'll be suspicious for malingering. Now, I have the luxury of working with a physical medicine doctor who also will do reliability testing. So if I ever really have concerns about somebody who might be, whether it's malingering or exaggerating, there's a lot of people who have underlying problems. They haven't been heard long enough. And so they just keep getting louder and louder and louder about it. And that's not malingering, right? At that point, you're just kind of trying to get someone to listen to you a little bit. And so there's trying to figure out, like, what is your goal of exacerbating your symptoms? And but that's one of those, I always joke with my colleagues, like, they don't get numbers the way I get numbers. So the beauty of eye movements, they're objective. At Berkeley, I did a lot of my training and my residency with patients who were aphasic with stroke. So they couldn't tell me what their problems were. I had to kind of figure it out. And I think that's the beauty of eyes and why eyes are such a wonderful objective biomarker, because if somebody comes in and you'll see them too, the people who malinger usually, like, everything is the worst. And most of my concussion people who are really suffering and they've got neuralgia and they've got migraine, they don't complain nearly as bad as the people who are malingering, right? So you can get an idea. I feel like if you really do a lot of it, and that's the big thing for me is brain injury. If you've seen one brain injury, you've seen one brain injury. So the more you see, the easier it gets. And then for the ones that I have that are tricky, most of my therapy is home based. Just because getting in the car, feeling gross in the car, getting in my office, feeling gross in vision therapy and going home, that sounds terrible. Not a recipe for success. So we do a lot of home based, but we do check-ins. And if we don't see them getting better and the speed they should be getting better, we'll make them go in office. And we have an occupational therapist who I absolutely adore. And her vision therapy is going to end up being like, she essentially does kind of work hardening for your visual system. And she tries to mimic your work environment using, sound and using different lighting and things like that. And so she pretty much makes your vision therapy worse than going to work. In which case, like, by the time you're done with her, you can go to work, because if you can survive her visual work hardening program, you can definitely go back to work. Uh, it is hard. It can be tricky sometimes.
I'm not gonna lie. I mean, I feel like I could just keep asking you questions, and I'm fascinated because this is so out of. I mean, I've my whole career has been in cataract refractive surgery. I mean, preoperative, postoperative patients. Looking for complications associated with ocular disease related to anterior segment, and the 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 neural system to me has always been that kind of high order treatment that is just like it's beyond me. And just listening to the passion you have is just absolutely, I mean, I'm blown away. I'm like, now I just want to you know, keep learning more. But at the same time, too, though, I also realize that, I'll never have the ability to manage patients because I don't have the empathy like you do. I teased Jackie for my 2 listeners here. I teased her. I said this is gonna be a 4-hour podcast, but it easily could be, but I don't wanna take up, everybody else's time. So I want you to do me a favor, tie this up with a little bit of a bow and just what do you want our colleagues to know? I know that you talk and how do I know this? Because I went to your website. I know that you talk about ergonomics for driving and ergonomics for sitting and things like that. But what is something that you think that we should know about neural health before these patients get to you, or anything, just anything you want to say?
I think my big thing would be, if you don't treat it, don't ignore it and find someone who wants to treat it. And I say that because even if you don't have a neuro-optometrist in your area or even a neuro-ophthalmologist for the diagnostics, there's a lot of other disciplines that can be helpful, like physical therapy. I will say, working with our physical therapist, I've learned a ton about the neck. And that's the one pearl I've learned, is that in our clinic, the first 3 things that we always fix for people are sleep, pain, and mood. No rehab works if someone's not sleeping, if they're depressed and anxious, or if they're in incredible amounts of pain. And so a lot of times my job isn't necessarily fixing their vision problems. It's getting them to fix their sleep, pain, and mood before they come back to see me again. It's amazing how much more compliant they are with all the things I want them to do when they're sleeping and they're in a good mood and they're not in pain. So
Perfect.
those are my biggest.
That's a great way to end it. And I'm going to change that to PMS, pain, mood, and sleep, because I just think it rolls off. It's like, oh, we got to work on your PMS. And especially for the male patients, right? I think that would really resonate a lot better for them.
Yeah,
So you can use that. I'll let you use that,
I'll
Jackie.
steal that. Thank you.
Yeah. Jackie, you are amazing. You're a star. I'm honestly, I'm in awe. I'm going to just, I'm going to start looking at these patients a lot differently before I refer them out. But I do think that, one of the good take home messages too is that, intra-optometric referrals, finding people who, specialize in things you can't do and just not giving up on our patients. I think it's fantastic. So, Jackie, thank you so much for taking the time to come to Collaborative Corner. And really appreciate you. And everybody who joined us, thanks for listening. Enjoy the rest of your 2025. And we will be back sometime in 2026 with more fun and whatever else we call this. So thank you. And thanks so much, Jackie.